our
our
speaker.
speaker.
Over to
Over to
Bijan.
Bijan.
Thank you, sir, and good evening, everybody. Today we have got the 12th lecture of the series, and our today's speaker is Dr. Bikramjit. Bikram is a DM from PGI Chandigarh. He is an intensivist in Bhagirathi Neotia Hospital, Kolkata. He is an excellent speaker. Today's his talk will be persistent pulmonary hypertension in newborn. Before he starts, let me speak few words about PPHN. Hypoxic respiratory failure is a nightmare for a resident. And many times persistent pulmonary hypertension or PPHN may occur as a primary pulmonary hypertension or secondary. So, and that is sir, actually echoing. So it may be primary or it may be secondary. And most of the time it is secondary. Sir, sir, but there is echoing going on. So in our clinical practice, mostly what we find is a
Now echo is
secondary
there?
causes of. Now it is not there.
Okay, fine.
Most of the time in clinical practice, we find the persistent pulmonary hypertension because of secondary origin, maybe because of asphyxia, RDS, mechanism aspiration syndrome, etc. And once it sets in, it is very difficult to manage a baby with persistent pulmonary hypertension because one of the uh, uh, drug, which is the approved drug, is nitric oxide. Many a times it is not available in many centers, but we have to manage a baby on persistent pulmonary hypertension. I'll not speak much more, and Bikramjit will speak all about persistent hypertension in newborn. Now over to Bikram. Please start your talk.
Thank you,
Thank
sir.
you.
Thank you, sir. So today's topic of discussion, as sir has already introduced, is PPHN, and we all are familiar with it, and we'll be going through it in this. So the overview of presentation would be we'll go a little bit into the pulmonary vascular development and the fetal circulation and its physiology, and how the normal transition happens. Then we'll dive into the definition, the types of PPHN, the classification, pathophysiology, the hemodynamics involved, the clinical features, and the management. Next slide. A little bit about the vascular development. It starts from the embryonic phase. The lung buds arise from the ventral aspect of the foregut around 5th week of gestation, and the pulmonary trunk is derived from the truncus arteriosus, which divides into the aorta and the pulmonary trunks around 8th week of gestation. And the pulmonary trunk then connects to the pulmonary arch arteries, which are derived from the 6th branchial arch arteries. And this is how the development of the vessels are happening. And regarding the mesenchyme, it is developing present around the pre-acinar stage is around the 20th week, and the intra-acinar arteries develop during the alveolar phase of the lung development. Next slide. So the lung septation and alveolarization begins at around 32 to 36 weeks. The vascular growth and branching are coupled with the growth and branching of the alveolar epithelium. And the pulmonary capillaries surround the thinning alveolar walls, providing the increased alveolar and capillary surface area. And the lung blood vessels actively promote the alveolar lung growth during the development and contribute to the maintenance of alveolar structures. And as the lung growth progresses, the number of the small pulmonary arteries increases both in absolute terms and per unit volume. So that's a little bit about the development. So let us go. Now, what happens? You can see in the in utero. Placenta is the gas organ for gas of exchange. The POT in the umbilical artery is very low, close to 15 to 25. The PO2 of the umbilical venous blood is around 20 to 40. And placenta has the lowest resistance in the fetal circulatory system and receives around 40% of the total cardiac output. Now, despite being so low PO2, still the fetus is not hypoxic because of the presence of fetal hemoglobin, which has very high affinity for oxygen. And as a result, the fetal tissues are perfused with blood, which are higher than even than adult. And to add on to it, the fetus has a lower oxygen demand. So only 10 to 20% of the combined ventricular output is directed to the pulmonary vascular bed, and that is primarily because the pulmonary vascular resistance is kept at very high, and the presence of patent ductus arteriosus, which diverts it from the lungs, and a lower resistance of placental circulation, which facilitates towards the placenta. The low fetal PO2 contributes to this increased pulmonary vascular resistance. And the ductus arteriosus remains patent because of the presence of fetal prostaglandins as compared to endothelins, and prostaglandins we know are vasodilators. Next slide. So the low oxygen tension, the low basal production of the vasodilators, that is prostaglandin and nitric oxide, and increased production of vasoconstrictors, that is endothelin 1 and leukotrienes, and serotonin may also contribute to this high PVR. So that's how the PVR stays high, and oxygen tension increases, the systemic vascular resistance starts increasing at birth. So at birth, this is the change which is happening. Next slide. So after birth, what you can see is that immediately the pulmonary vascular resistance starts falling down, as a result of which the red line, that is the pulmonary blood flow, dramatically increases, and the pulmonary arterial pressure, you can see, starts coming down, and it is happening, you can see, within close to within 5 minutes, and it is reaching its plateau. The pulmonary blood flow immediately increases within the first 5 minutes. Next slide. Now, what helps in this is the closure of the fetal shunts. You can see with the increased pulmonary blood flow, the pulmonary venous return will increase. This will increase your left atrial pressure, which will lead to closure of the foramen ovale. And at the same time, once the pulmonary vascular resistance falls, the oxygen tension increases, and this leads to functional closure of the ductus arteriosus. The stimuli for reducing pulmonary vascular resistance comes from the lung inflation. You can see there is a rapid increase in the structure of the alveoli. It gets stretched. The alveoli, the epithelial cells are stretched, which increases their surface area. More oxygen diffusion happens. The alveolari blood vessels are exposed to more oxygen, as a result of which pulmonary vascular resistance falls further. Next slide. The increase in this oxygen tension leads to a marked myogenic response, and this leads to increase in the production of the nitric oxide, and it may also promote the rapid endothelial spreading. So oxygen, it turns into a cycle on itself, which more oxygen helps in delivering more oxygen further on. And the shear stress, the initial increase in the pulmonary blood flow increases the shear stress in the pulmonary vasculature, which further promotes rapid vasodilatation. So as a result, the oxygen and the blood flow keeps on increasing exponentially. Next slide. This slide will be coming later on also, but what you can see is that these are the compounds which are involved. So one is nitric oxide, where it stimulates the enzyme guanylate cyclase, which results in production of cyclic GMP, which is the vasodilator. Prostacyclins, which increase the production of cyclic AMP, which is your second vasodilator. On the other hand, you can see endothelins, they are your vasoconstrictors. Now, sildenafil acts at the PDE5, which prevents degradation of cyclic GMP, and milrinone acts at PDE3, which prevents the degradation of cyclic AMP. So this is the mechanisms of action of these two drugs, which will be again coming on later. And bosentan, you can see, is inhibiting your endothelin. Okay, so by definition, PPHN is basically a disruption in this normal perinatal fetal neonatal circulatory transition. And it is characterized by a few things. The primary thing is elevated pulmonary vascular resistance. That is the primary thing, which leads to a predominantly right to left extrapulmonary shunting, which leads to severe hypoxemia, the incidence of which is around 1 to 2 per thousand live births, primarily which is seen in full term and post term infants. What are the types of this PPHN? It can be maladaptive, it can be because of excessive muscularization, it can be because of hypoplasia. Next slide. So PPHN you can see can be both reversible and irreversible. The irreversible ones are the ones which do not have good outcomes. Here the pulmonary pressures continue to stay high. These are the ones like pulmonary hypoplasia, the alveolo-capillary dysplasia, surfactant protein deficiency. In these conditions, usually your PVR never falls, and as a result, your hypoxemia never improves. On the other hand, the ones which are reversible, you can see they can be again divided into pulmonary causes and non-pulmonary causes. Amongst the pulmonary causes, the common being RDS and meconium aspiration, then again CDH and pulmonary hypoplasia. And amongst the non-pulmonary ones, you can see the hypoxemia, AV malformations, certain maternal drugs like NSAIDs. So these are the ones which can be non-pulmonary causes of reversible PPH. Next. So this increased pulmonary vascular resistance can come from these four sectors. One is the pulmonary vascular remodeling. Next. So that is primarily because of the muscularization of the non-muscular intraacinar arteries, which leads to increased medial thickness of these muscular arteries, which leads to decreased cross-sectional area of the pulmonary vascular bed, as a result of which the gas exchange is affected and it leads to hypoxemia. Pulmonary hypoplasia is primarily because of alveolar and pulmonary arteriolar underdevelopment. Reversible vasospasm is primarily seen in conditions like hypoxia, and it can be exaggerated by acidosis. And myocardial dysfunction, the RV failure, results in the altered diastolic compliance, and which ultimately leads to biventricular failure. That means LV dysfunction also happens because of hypoxemia, and which leads to increased pulmonary venous hypertension and secondary pulmonary arterial hypertension. So both ventricles continue to fail in your myocardial dysfunction because of the hypoxemia. And mechanical factors like low cardiac output and hyperviscosity, they can add on to this. Okay, so continuing with the pathogenesis, there are basically two forms of PPHN. One is the functional one and one is the organic one. So the functional one is primarily because of pulmonary arteriolar vasoconstriction, and organic one is primarily because of the structural changes, which is primarily because of the muscular tunic hypertrophy, which happens in under chronic exposure to fetal hypoxia, which we'll discuss later. And these poor pulmonary vessels underdeveloped, so which leads to higher PVR.